attendees of this CPC today. Today we have a grand CPC. My name is Professor Chan Lai Fong from the Department of Psychiatry, and I would like to actually introduce briefly all the speakers today, whereby the topic is navigating the maze, a child in adult's body. First of all, Dr. Divya, our medical officer who is doing the child posting, will present the case presentation, followed by Dr. Hajar Muhammad Salleh Sahimi, who is a psychiatrist and our child fellow, who will talk about differential diagnosis of challenging behavior, followed by our pediatrician, Dr. Syanaz Ghazali, who will also give input by a team member who is a pediatrician and a genetic consultant, Dr. Keng Teik, followed by behavior intervention by our clinical psychologist, Puan Khairunnisa Mohd Jasri. And then lastly, but not least, our associate professor, Dr. Salwina Ismail, our consultant psychiatrist, to talk about the case in depth and a deep dive into it, and we'll followed by a short Q&A. So I'd like to introduce our first speaker up to the stage today, Dr. Divya. The floor is all yours.
Okay, thank you very much, Prof. Chan, for the warm introduction. Hi, good morning to everyone, everyone present here. My name is Dr. Divya, and I'm a postgraduate trainee in psychiatry. So today I'll be presenting a case for Grand CPC, and it is entitled Navigating the Maze, a Child in an Adult's Body. So this is a case of Miss NSA. She's a 21-year-old Malay female. She's single and still staying with her parents. So she came in with the chief complaint with worsening tantrums at the age of 6 years old, associated with head banging, rolling on the floor, hand biting, pinching her mother, hitting her mother if she does not get what she wants. Frequency about 2 to 3 times per day or even more, and lasts about 30 minutes, and no specific trigger. As for her history of presenting illness, Miss NSA actually started throwing tantrums at the age of 3 years old, where she had the associated symptoms such as head banging, rolling on the floor, hand biting mannerism, particularly her middle finger, hits or pinches her mother when she does not get what she wanted. She usually settles down when the mother scolds her or leaves her alone. However, there was no specific trigger. And during this early phase of life, Miss NSA was actually taken care by her maternal grandmother. And they practiced permissive parenting, whereby they would actually attend to all her requests and all her demands. Because of this behavior, mother had to resign her job to take care of Miss NSA, and because grandparents could not manage her alone. And at this point of time, at 4 years old, she was actually attending special school about once a week, and she had multiple changes in classes due to her persistent behavioral issues. She also had difficulty in paying attention. However, there was no hyperactivity noted. She was unable to be enrolled in a normal kindergarten because of behavior, as well as her behavior of refusing to comply with toilet training, whereby she tends to hold her urine when she's upset. Sometimes even when passing urine, she passes around all over the floor. She passes urine even at night on the bed. She also exhibited the habit of touching and playing with her feces in her diapers after she passes motion. Otherwise, at times, she also had behavior of inserting tissue paper into her mouth or even her ears, which was quite dangerous for her. However, at 6 years old, her tantrums started becoming worse, whereby it was more challenging and distressing to the parents. She also started developing sleep issues, whereby she started sleeping shorter at night, wakes up multiple times at night to play or to eat. And by play means she goes to the kitchen, play with raw cooking ingredients like the rice, flour, and she creates a mess. And parents had to keep the items locked all the time because of her behavior. And she likes to eat snacks at night, and then she tends to fall asleep while eating. And she also sleeps during the daytime. She shouts and screams at night out of a sudden. However, she still appeared to have a very clingy behavior towards her parents, although at times she would hit and pinch her mother when her demands are not met. She had multiple sensory-related behavior. For example, she refuses to wear clothes, especially at night, and sometimes even when leaving the house. She is very choosy with her clothing materials, choosy with her food. She prefers more carbohydrate content and also soft diet most of the time. She also started exhibiting more frequent self-injurious behaviors such as tongue biting and head banging, and this then required the referral to child psychiatry at the age of 6 years old. And she was seen by our psychiatrist, and she was started on melatonin, 3 milligrams on night, to help regulate her sleep and also to refer to occupational therapists to intervene in her behavior. However, not much of improvement noted in terms of her sleep and behavior. Subsequently, she was started on a low dose of risperidone, 0.5 mg on night. In terms of her sleep, there were noted improvement, more regular, longer hours of sleep at night, no side effects noted. However, behavioral-wise was still about the same. And at 11 years old, she started using vulgar words out of the sudden to scold anyone, including parents, teachers, therapists, doctors, even during her visits. And it's very sudden and abrupt. At 12 years old, she attained menarche, and because she could not take care of her self-hygiene to begin with, she had difficulty with her menses. So parents decided to seek help from the gynecologist to seek for intervention to stop her menses. And during her teen phase, of course, with puberty comes, she started exhibiting more interest towards the opposite gender, whereby she starts screaming, shouting, singing really loudly, even at public places to catch attention of the opposite gender. This has become quite embarrassing to the parents as well. And she has the habit of impulsively demanding things to be bought for her, especially food, which then she never finishes eating them. And it became more distressing to the parents. As she was going through her occupational therapy sessions in Hospital Kajang at this point, due to logistic reasons, her behavior was still about the same. However, at 19 years old, her behavior became more unmanageable, whereby she refused to follow instructions, unable to engage her with any given task. She also had an aggressive episode where she pushed the therapist, she kicked the tables, she pushed the chairs away as well. Hence, she was then discharged by the occupational therapist in Hospital Kajang due to the behavior, and she was referred to us back again for clinical psychologist's purpose for intervention and continuation of care at the age of 20 years old. So after years of multiple medication adjustments, regular psychologist reviews, psychiatry rehab sessions, there were noted improvement in her behavior as per her sleep was improved. In terms of toilet care in the past few weeks, she's able to understand the concept of it. She's slowly able to understand the importance of wearing clothes as well. Otherwise, there was no sudden rapid recurrent motor movements, no seizure, no history of trauma. So just to recap her presenting illness in timeline form, her symptoms in terms of her tantrums actually started at the age of 3, worsened by the age of 6 years old, although there was no specific trigger, and she was referred to child psychiatry at that point. Her symptoms started worsening, especially during the 12 to 17 years old, during her teen phase, where she attained menarche, started gaining attention from opposite genders. At 19 years old, aggressive episode at the OT session, and at 21 years old, currently under our psychologist follow-up as well as psychiatrist follow-up, she's slightly a bit better than what she was in the past. So for medical and surgical history, she has multiple comorbids such as hypercholesterolemia and hypothyroidism, and this was something noted in the recent blood test, and so she's yet to be started on medication. She's obese and she's taking medication for that as well. There is chronic ear infections, otitis media. She has mild bilateral hearing loss. She induced amenorrhea on Mirena, currently under gynecology. Previous release of tongue tie, bilateral high myopia and dry eyes under ophthalm, cracked and thick heel callosity, as well as dental caries due to her poor oral hygiene. She attained menarche at 12 years old, and she's on Mirena for induced amenorrhea. As for family history, she comes from the siblings of 4, all 4 girls, and she's the youngest. And her parents are her father is 62 years old, her mother is 58 years old. And her second sister, the 29-year-old girl, currently she's 29, she's single, she's working. She has history of encephalitis when she was a baby, as well as she was diagnosed with mild intellectual disability as well. Otherwise, in terms of a 3-generational family tree, there's actually no known family history of any psychiatric illness, genetic conditions, inherited disorders, neurodevelopmental disorders, and no consanguinity as well. As for attachment and parenting, she was mainly taken care by her maternal grandparents until the age of 3 years old. Subsequently, the mother came into the role of taking care of her with the help of grandparents as she was growing. However, they all practice permissive parenting, or whereby they always give in to whatever the patient requests or demands. As for her birth history, her mother was 38 years old when she conceived Miss NSA. Mother's antenatal history-wise, there's hyperemesis gravidarum, requiring her hospitalization about 2 to 3 times, frequent migraine requiring medications. Otherwise, antenatally, no other issues. Not exposed to any teratogenic exposure as well. Girl was born through elective cesarean, 3 kg birth weight, no complications as well. However, when she was born, the attending doctor noted that she had soft dysmorphic features such as brachycephaly, white fontanelle, low set ears were noted, and hence then she was referred to pediatrics HUKM. Immunization-wise, she completed up to age. As for developmental history, for gross motor, she actually started crawling at the age of 12 months old. She pulled herself to stand at the age of 1 year and 5 months, unable to sit without support till about 2 years old, unable to walk without support after 2 years old. Fine motor-wise, she's unable to scribble to and fro till about 3 years old, and she had immature pincer grip till 3 years old. Language-wise, she only started babbling at the age of 1 year and 5 months, able to say her first word at 2 years old, some meaningful words which can be understood. Social-wise, she throws tantrums if she's angry since age 3. She's able to share hugs with mother when she feels like it. Otherwise, she's unable to play in a group. She's unable to do a proper toilet training even till about 7 years old, which she also refused after that. So overall, there is global developmental delay in all the categories for developmental history. Currently, as for her present developmental progression, she still has episodes where she cannot comply to toilet training, so she tends to pass urine in her pants, especially at night. She still plays with toys, not able to read, write, count, unable to tell the day, date, time, does not understand the concept of money, she cannot engage in continuous conversation. ADL-wise, still semi-dependent, especially for shower, brushing her teeth. And emotionally, she's unable to tolerate any frustration, or she has that immaturity in her emotion, where she cannot take no for an answer, and she expects things to be done as per her request, to be granted immediately. For education-wise, she started attending special school since the age of 4 years old, where the school mainly focused on music, dancing classes. Otherwise, no particular formal education was done. And also, there were also focus on self-care as well. However, as she was going into a teen phase, noted it was worse, her behavior-wise was worsening. She was not able to sustain in one class. She had multiple changes in class. So at the age of 17, the mother had to stop her from school. Subsequently, she did not continue her studies. These are her current medications. She's on antipsychotics, risperidone, aripiprazole, melatonin, clonazepam. Metformin is actually for her obesity that she's currently on. As for her mental state examination during the last review seen, she's a 21-year-old Malay lady wearing casual t-shirt and pants with hairband, carrying a bag with a cartoon figure that is usually carried by children to school while holding mother's hand when she walks into the interview room. She's wearing a thick spectacles and mask attached to her ears with a band of colorful beads attached to her ears. She had poor eye contact. She initially sat in the chair allocated to her and greeted. However, later she pulled herself closer to the doctor and sat closer to the doctor with no boundary. She was fidgety, opening up her bag and walking around the room while having conversation with the mother. She was fairly cooperative when answering certain questions while walking around. Subsequently, she started sitting on her mother's lap and asking her mother to hug her as her mother was answering the doctor's questions. And the interview room seemed it was under Miss NSA's control at that point of time. As for her speech, she could speak Bahasa Melayu, unable to engage in continuous conversation. Some of her pronunciations were rather not clear as well. She speaks about 4 to 5 words in a sentence and repeats a few times if you don't attend to it. She's able to say a few words like saya mau mama, ayah dekat luar. At times, she can give commands to her mother to answer some of the questions if she does not feel like answering, and sometimes asking her father to come in and answer questions as well, and occasionally disrupting the conversation between doctor and mother. As for her mood, there's no irritability seen. She appears rather cheerful, happy mostly during the recent session. No tantrums such as screaming, shouting, or rolling on the floor. She did not exhibit any abnormal behavior suggesting any perceptual or thought disturbances. As for her cognition, she's aware that she's at the hospital for her appointment with the therapist. However, she addresses the therapist informally by name, and she does not know the day, date, or time. As for physical examination, she's alert, conscious. She exhibits an immature childlike gait pattern characterized by bilateral feet consistently pointing inwards during her ambulation. There is the gait is narrow based. There's reduced heel strike coordination as well as reduced arm swing as per observation. As for her facial features, she has broad and square shaped face with deep set eyes, full cheeks with a prominent lower jaw. And she also has right pseudostrabismus, as well as she's obese as per her BMI charting, 29.32 kilogram. As for her blood investigations, her FBC, RP, LFT were all rather normal. However, in the recent blood investigation, her thyroid function, there is hypothyroidism as well as there is hypercholesterolemia for her cholesterol profile. Otherwise, investigations in the past for radiological imaging, for ultrasound brain, for MRI brain in the past were all rather normal. And for investigations in terms of genetic testing, her cytochrome analysis is apparently normal, a female karyotype. As for her microarray analysis, back in 2014, shows a loss of long arm of chromosome 17, which will later be explained by our pediatrician during her presentation. And other investigations such as echo was normal. And for psychometric assessment, for Winland Adaptive Behavior Scales, for her ADL basically, she actually scores a low score. And this will be further explained by our clinical psychologist later. So that's all from me. Thank you very much.
Okay, hi, good morning. I'm Dr. Hajar. So today I'll be presenting about behavioral problems among children with Smith-Magenis syndrome. And I will also go back to our patient and I will do some differential diagnosis and a bit of formulation for this patient. So just a bit of summary on our case just now. Miss NSA, her behavior includes temper tantrums, for example, self-injurious behavior, head banging, biting fingers, and also harming the mother as well. On top of that, she has been playing with her feces, and even up until now, there's a lot of emotional dysregulation where she would have intense shifts of mood and also sleep problem, and oppositional behavior whereby she would refuse to listen to authority figures and quite argumentative. On top of that, inattention and hyperactivity, she would fidget and not able to sit still and couldn't focus. And also passing urine outside of the toilet, on the bed or in the room. And also poor cognitive and adaptive functioning as well. So a bit of, in general, what are the characteristic behavior in children with Smith-Magenis syndrome? So the first one is sleep disturbances. We see that they would have inverted circadian rhythm. They would fall asleep during the day and not able to sleep at night or not sleeping at all. Difficulty falling asleep, frequent nighttime awakenings and early awakening. So this is postulated to be associated with disrupted melatonin production. Self-injurious behavior, as our patient just now, head banging, biting, skin picking, and also inserting objects into bodily orifices, which is what is happening in our patient. Emotional dysregulation, frequent and intense temper outbursts, mood lability, mood shifts, difficulty to control their emotions, especially when there's changes in the routine. Attention-seeking behavior, this is also seen in our patient. There's a very strong need for adult attention. So whenever the attention is diverted, they would have disruptive behaviors. And they would prefer one-to-one interaction with adult over children or at the same age. So this is very important, which will be discussed further by our therapist in terms of how we're going to manage that behavior. And stereotypic behavior such as self-hugging, hand licking, flapping, body rocking. So usually serve as self-soothing mechanism. So what are the differential diagnoses of this behavior? So even though this patient has been diagnosed with SMS, we still have to look at the behavior and figure out, is there any other comorbidities, either psychiatric or medical comorbidities, or is there any other environmental factors or parenting factors that can contribute to the behavior. So differential diagnosis in terms of neurodevelopmental behavior disorder, we should consider ASD, autism spectrum disorder, intellectual disability, ADHD, or communication disorder, or is there any other genetic syndrome? Psychiatric disorder, whether there's disruptive mood dysregulation disorder, bipolar disorder, oppositional defiant disorder, conduct disorder, or anxiety disorder. And is there any other medical condition? Sleep problem, seizure disorder, sensory processing issues? Is there any pain? She's passing urine outside of the toilet. Is there any urinary problems? Is there any environmental factors? Is she in stress? Is there any changes in the environment? Did the sister just got married, have kids? Are the children staying with her? Is there any new changes in her environment? Communication barriers, as we know, there's limitation in terms of communication. So is she having problem expressing her needs or her emotions? Sensory overload, she also has some sensory issues, whether that also contributes to the behavior, and attention-seeking behavior. She's on medication. Is there any side effects from the medication? And the last one is parenting. As we know, there's multiple parental figures, grandparents when she was younger, and also parents now who are getting older, and there's older siblings as well, and all of them are using different types of parenting style. So were there any inconsistency in terms of the parenting? And as we know, the grandparents were permissive when she was younger, and does that have any contribute to the current behavior? So what do? We look for the points for and points against for different differential diagnoses. I hope you can see that. So the top differential diagnosis or comorbidity will be intellectual disability. And just now Dr. Divya has presented the Vineland score, which was low. And we were not able to do the Wechsler Adult Intelligence Scale because she just couldn't sit still and couldn't focus, and she was not able to read and write. And so clinically, we assumed that the IQ would be low. So intellectual disability will be higher up in our differential or even a comorbidity now. Sensory deficits, she has bilateral high myopia. She has bilateral, mild bilateral hearing loss. There's chronic otitis media. So there's definitely a limitation in terms of her eyesight and her hearing. And there's possibility she has sensory processing issue. She tend to strip naked and not wearing any clothes, whether it's due to hypersensitivity to certain texture, and she's quite a picky eater, so it's possibility that there's some sensory processing issue as well. ADHD is also quite high up there. She's not able to sit still, she's not able to do activities quietly, so just fidgeting, and she's even in the consultation room, she's walking around. So, but however, this could be due to a lack of understanding of the social norms in the room, and possibly the ID as well. And it's better explained by Smith-Magenis syndrome. Autism spectrum disorder is also a possibility due to the speech delay, and there's query, lack of empathy. She's not able to see on the other person's point of view. However, she does not fulfill the criteria for ASD. She does not have any restrictive repetitive interests or behavior that you could see in ASD. Disruptive mood dysregulation disorder is due to the temper outburst, but this temper or irritability can be also seen in SMS. Oppositional defiant disorder, she's argumentative and she's not following authoritative figures. But the tantrums only happen when her demands are not met. And there's no resentment or vindictiveness that you would see in ODD. Bipolar disorder is lower in the list due to the irritability and poor sleep pattern and the shifts of mood. But there's no distinct depressive or manic or hypomanic episodes and no other related symptoms for bipolar disorder. Medication side effects is a possibility. She's on risperidone, aripiprazole, clonazepam. These are actually prescribed for the behavior in the beginning, but she might also have paradoxical agitation from the medication. So those are the comorbidities or differential diagnoses for the behavior, but we also have to look at the environmental and parenting factors that might contribute to the behavior. So whether there's any disrupted routines, any new changes, unexpected that we didn't prep the patient before, that could be due to or trigger the behavior problem. Inconsistent parenting, as I mentioned earlier, multiple parental figures with different forms of parenting. Initially, when she was younger, grandparents were more permissive, allowing her to do anything she wants. And she was smaller size, so they were able to control her. But now as she grows older, she's bigger, and now she's getting more obese, and the parents are getting older. Parental burnout happened, and now they're not really able to set boundaries for him at this age and giving in to her demands, which may perpetuate the behavior. Sensory overload, when there's too many people, noise and bright lights, this can overwhelm her and trigger her behavior. And also frustration from communication difficulties can also trigger the behavior as well. So the underlying mechanism for behavioral problems, it could be the genetic factor itself affecting the brain development and function. Sleeping, she's not sleeping at night, so probably she's tired during the day and causing more behavior in the day. As mentioned, communication challenges and rigid expectations, so she's not flexible to accept any changes unexpectedly. So as we go to case formulation, just generally, there are many types of formulation, but I'm just going to talk about these two types, narrative formulation and biopsychosocial formulation. So in terms of the narrative formulation, allow me to read from this. It's easier for you to follow. This 21-year-old woman has Smith-Magenis syndrome and shows persistent tantrums, especially when her needs are not met. These behaviors have been present for many years, but become more severe, especially during after puberty. As a child, she was mainly raised by her grandparents, who were caring but intended to be permissive and inconsistent. This may have made it harder for her to develop emotional regulation skills and led her to use tantrums as a way to get her needs met. The core features of Smith-Magenis syndrome, such as intellectual disability, sleep and sensory problems, make it harder for her to manage her emotions. Her visual and hearing problems further limit her ability to understand her environment and communicate effectively, adding to her frustration. During puberty, hormonal changes and increasing social demands likely overwhelm her already limited coping skills, leading to more frequent and intense outbursts. Currently, her tantrums are likely being reinforced by her environment, where caregivers give in to avoid escalation. This is because as she grew older, her body size has increased and her elderly parents were not able to physically manage her anymore. Despite these challenges, she has a supportive family and tends to do better in a more predicted and structured environment. And this is used to guide her treatment, which later on our psychologist will present about her treatment. So in terms of biopsychosocial formulation, I think most of our medical students and our trainees knows this. what predisposes her to having this behavior is the genetic condition itself. She has sensory deficits, and that could predispose her for having more behavioral problem. She's not able to regulate her emotions well, her poor scoping skills, poor frustration tolerance, inconsistent parenting, lack of boundaries, lack of communication skills. So this predisposes her for the behavior. What precipitate or making the behavior worse is puberty, and maybe sensory processing problem, and psychologically lack of adaptive coping mechanism. And socially, during that time, there's increased social expectation as well for her, and which causes her to be more frustrated. What perpetuates the problem is parents not able to manage her behavior due to her bigger size, and ongoing sensory problem and sensory deficits, and then tantrums reinforced by permissive responses by the caregivers, and ongoing communication difficulties. But what protect her from, what are the protective factors for her? Showing improvement in psychotherapy, which our psychologist will present later, and she has a very supportive family. So how do you tease out what are the underlying mechanisms? It's basically by analyzing the behavior. So what are the triggers? What are the consequences that she attained from behaving that way? So we use the ABC charting, antecedent, behavior, and consequence chart, where you would document the patterns of behavior and what are the timing and what are the consequences that she would receive whenever she have this behavior. We also need to assess medically, do a full medical workup to see whether there's any problem physically, and also some sensory issues. Check also for medication side effects as well. Assess if the behavior serves as a communication function, whether she is actually trying to communicate something to the parents or to us, and also evaluate receptive and then expressive language ability. And then also do an environmental review, whether there's any recent stressor or changes in her life, and also evaluate the family dynamic and parenting approaches. And how to tease out comorbidities is by doing a comprehensive assessment, get a very detailed developmental history, and compare behaviors to the Smith-Magenis syndrome phenotype. Is there anything that is out of the typical phenotype of SMS? So that might be something more environmental or parental factor. Observe the patient, and then involve multidisciplinary team, the genetician, ENT, ophthalmology, psychiatry, psychologist, and OT, and coordinate the finding across discipline. There's no point having multidisciplinary if you don't communicate with a different team. And then ongoing monitoring. So this is my last slide. Back to our case. So what is the behavior? Is it due to SMS or is it due to something else? There's no right or wrong answer, but SMS itself does have behavioral issues, sleep problem, cognitive impairment, speech and language impairment, impulsivity. We need to figure out whether this is actually urinary incontinence. But we have referred to the urologist, and that has been ruled out. So probably this is more behavioral, and that can be teased out. She has hearing and visual impairment, whether she is still needing anything to improve that. Is there any psychiatric comorbidity? We have established the high possibility of intellectual disability, whether there's any oppositional defiant disorder on top of that, which is quite unlikely. Whether this is a learned behavior, because the behavior has been proven to allow her to get what she wanted, because family gives in to her. And is it inconsistent parenting, causing more difficulty to enforce boundaries for her? So by understanding all this, we can plan for an approach for her in terms of psychotherapy. That's all from me.
Okay, Assalamualaikum and a very good morning. I'm Dr. Syanaz from the Pediatric Department. Thank you, Department of Psychiatry, for inviting me today. So the topic that is given to me is navigating the maze, a child in an adult's body. And I thought this is a perfect title because we have a 21-year-old lady who's, chronologically is 21 years old, yet developmentally she's behaving like a 4-year-old. And the journey has been, the journey has been very challenging from the beginning. So baby S was first seen in the pediatric clinic at the age of 6 months old for dysmorphic features and feeding difficulty. She had gastroesophageal reflux disease, which was treated with anti-reflux medication. At that point, she was also noted to have global developmental delay as her developmental milestones were not corresponding to her chronology age. So she had head lag when pulled to sit. She had rattle only momentarily when it's placed in her hand. She was just cooing and there was no babbling, and she did not respond with pleasure to any social gestures. So her developmental age was around 3 months old. She was then started on early intervention programs such as physiotherapy, occupational therapy, and speech therapy, which did help her to some extent. The initial investigations for GDD was done and there was no significant results. On examination, her growth parameters were on the second centile, and she has dysmorphic features. So if you can appreciate, she has frontal bossing with flat nasal bridge. She has a long philtrum with lid pushed up, prominent jaw. She also has prominent, sometimes rosy cheeks. She has deep set almond-shaped eyes with long, beautiful eyelashes. On further examination of the hand, it was noted that she has short, stubby fingers as well as the toes, right? She also has pes planus or flat feet. Her cardiorespiratory examinations were normal. She has no neurocutaneous stigmata. She was hypotonic, so she was a floppy baby. We continued to follow her up, and at the age of 3 years old, it was noted that she had really severe temper tantrums, which was beyond a normal terrible 2 or horrible 3-year-old, whatever you want to call them. So she had things like head banging and self-biting. She was then seen by our child psychologist as early as 3 years old and was started on behavior modifications such as star charts. At the age of 5 years old, we thought that we need further help. Hence, she was referred to our child psychiatrist. So in summary, we have a child here with dysmorphism, hypotonia and feeding difficulty during infancy with global developmental delay. She also have aggressive behaviors and sleep disturbances, which were all restricting parents and family from attending the social events. So what are the differential diagnoses, right? How do we approach a child with developmental delays, challenging behaviors, and dysmorphism? So first, think about the genetic. So the examples are chromosomal disorders and single gene disorders. So everybody knows trisomy 21 or Down syndrome. We have fragile X when you have a fragile site at the X chromosome. Williams, deletion at chromosome 7. Cry-de-cat syndrome, 5p deletion when you have these infants having like a really high-pitched cry like a cat, hence the name. And then Smith-Magenis, which is the hot topic for today. Rett, the mutation is at the MECP2 area. And of course, we have tuberous sclerosis and neurofibromatosis type 1 with classical neurocutaneous stigmata. Next on the list is paroxysmal disorders such as Zellweger and Refsum. So these kids, they also have hypotonia with feeding difficulties, and they have ears and eye involvement such as retinitis pigmentosa. Metabolic causes, so inborn errors of metabolism. This against infants, they usually present earlier, and again, they have like really non-specific symptoms like poor feeding, lethargy, seizures, encephalopathy. Sometimes they are more dramatic presentation, and they have metabolic acidosis with high lactate and ammonia. maple syrup urine disease, for example, they have all those features and nice smell of their urine, if you like maple syrup. Next is lysosomal storage disease. Examples are MPS, or mucopolysaccharidosis type 1 to 5, and mitochondrial diseases where the defect is at the powerhouse of the cell. So these kids would have multiple organ involvements, and they have developmental regression where they achieve certain milestones, but at some point of their life, they tend to lose the skills and they continue to regress. So some examples that we discussed earlier, so rat, the girls would come with a lot of stereotypical behaviors and epilepsy. Boys, they come with learning difficulties, challenging behaviors, and if you look at them, they have prominent ears, frontal bossing, they have narrow face with small chin, and they also have macroorchidism, so do your examination correctly. Williams syndrome, they have happy personality, so they are happy-go-lucky kids, and they are dysmorphic with congenital heart defects. Noonan, they have webbing of the neck and congenital heart defects like atrial septal defect and hypertrophic cardiomyopathy. And these are cafe au lait in NF1 as well as Ashleaf macules in tuberous sclerosis complex. Lysosomal storage diseases when they are malfunctioning of the lysosomes. So you have a lot of build up of your undigested materials within the cell. So these kids would have really coarse faces. They also have umbilical hernia with hepatosplenomegaly. And pediatricians observe the growth chart, so I thought I have to show you at least one here. You see these kids start to cross centile at the age of between 6 months to 12 months. They start to failing to thrive, or we call growth faltering. So they are short and they have big heads. So this is head of circumference chart. And the x-rays, you will notice they have oar-like appearance of the ribs, OAR, and they have beaking of the L3 vertebra in their x-ray. So investigations, how do we investigate all these children? Okay, for this particular girl, we sent our basic blood investigations, such as full blood picture, thyroid function test, just to make sure everything's normal. And we had to exclude inborn errors of metabolism. Hence, the lactate, ammonia, serum amino acid, urine organic acid, and blood gas were all sent, and they were all normal. MRI brain did not show any significant finding. And karyotyping is 46XX, which is consistent with a female phenotype. Because the clinical suspicion was towards a chromosomal abnormality in such presentation, so the test that was done was microarray CGH, which was then confirmed the diagnosis. Alternatively, if you're suspecting a disease of Mendelian inheritance, a better test to do is whole exome sequencing. Final diagnosis is Smith-Magenis syndrome, and the deletion is at the chromosome 17 at the P arm in the area of 11.2. Because this is a genetic case, I thought we'd do a really quick revision. So this is a nucleus and in a cell, and cell is the fundamental unit of a living organism, and there's chromosomes in it. And within the chromosome, there are genes, which are the thread-like structures, consist of DNA and proteins, and they are the blueprint to encode the genetic material. And human has 46 chromosomes, so chromosome number 1 to 22 are the autosomes, and chromosome 23 is the sex chromosome. The top part, or the short arm, is called the P arm, and the bottom arm, or the Q arm, is called the long arm. Okay. If we go further, you will see the 4 nucleotide bases of DNA. So there are thymine, adenine, cytosine, and guanine, and these are the building blocks of DNA. And A has to pair with T, and C pairs with G, right? And all this pairing is important for DNA replication. So if you want to imagine this whole genome is like a book, and in the book there are many chapters in it. and chapters are like the chromosomes. In each chapters, there are sentences, which are the genes. And in each sentence, there are words and alphabets, which are the amino acids and DNA. So if you want to imagine yourself, you are like a book where you carry half information from mom and half information from dad. And you have to look somehow rather like either your mom or your dad or somewhere in between. If not, you probably have some soft dysmorphism, maybe. Okay, so Smith-Magenis syndrome is when you have a deletion here in chromosome number 17 at the P arm, the location of 11.2. And this contributes to 90% cases of SMS. The other 10% of SMS is due to mutation of the RAI1 gene, and this mutation is also located on chromosome number 17. What else could go wrong apart from deletion? So there's duplication when some parts of the chromosomes, they duplicate. There is inversion. There are also insertions. And last is translocations when these parts, they swap places. So the test that was done for this girl is chromosome microarray analysis, or we call it CGH, or comparative genomic hybridization. This is the way to go if you have a child with global developmental delays, dysmorphism, and or multiple congenital defects, and you're suspecting a chromosomal abnormality. This test involves labeling the patient's DNA as green and the reference DNA as red. And all of this will be mixed and hybridized on the microarray chip, which contains probes for thousands of genomic regions. Following that, there'll be a computer analysis to scan the results. So if you're normal, you get a 1-to-1 ratio, whereas if there is less DNA binding to the region, your ratio will be 0.5-to-1, and that indicates a deletion. Whereas if you have extra binding to the region, there is a duplication of the chromosomes. So this test is not just technical, they are also very costly, and unfortunately it's not done in our country. So why do we advocate parents or patients to proceed with this test, even though we know that knowing the diagnosis will not cure the disease? Okay, so basically it's for the genetic counseling. So once we know this is Smith-Magenis syndrome, we can actually counsel the parents and the family. We can counsel them that SMS is de novo or by chance. Parents are not carriers. What are the recurrence risks in the next pregnancy? So once we know that parents have normal chromosome studies, we can counsel them that there is very low recurrence risk, which is less than 1%. Because in genetics, like a lot of any other things in life, nothing is 100% and nothing is 0%. So we counsel them as less than 1%. How about the siblings? You know, our patient has 3 older sisters. What are the risk factors for the offspring, for their sisters to have the offspring affected with the disease? So again, it's also less than 1%. So if the parents want for their future pregnancies, we can advise an early referral to the ONG site, and they can offer prenatal testing such as choreo venous sampling or amniocentesis with SMS-specific fish probes. That brings me to my last 2 slides. So the take-home message that I want people to go home with today is, if you see a child with developmental delays and intellectual disability, and intellectual disability refers to children more than 5 years old with GDD. So the term GDD we only use for kids less than 5, right? With challenging behaviors and dysmorphism, please think about genetic. It's not common, but think about it. Whereas if you see similar presentation in children without dysmorphism, so the kids with learning difficulties, challenging behaviors, but they have no dysmorphism. So think about common things, because common things occur more commonly. Hearing impairment, visual impairment, sleep deprivation, get a good sleep history, what time does the child goes to bed, how many hours of sleep, because you know that when someone is sleep deprived, they can be really cranky. Excessive screen time. So screen include everything from TV, mobile phones, whatever you have, laptop, gadgets. Okay, so children less than 18 months old should not be on any screen at all according to the guidelines, and children more than 2 years old is considered having excessive screen time is more than 4 hours. Again, it depends on the contents of the screen. Medical illness, so we have many future doctors in this room, so it's your job as doctors to make sure that the medical illness is well controlled, things like asthma, malignancy. Is there any malignancy that we are missing in this child? Why is this kid not thriving, right? I think psychosocial issues have been discussed a lot. Ask about family dynamics, divorce, parental illness, any bully or abuse that's making these kids having school refusal, right? Last but not least, neurodivergent. So this is where all the Ds come in again, ASD, ADHD, SLD, and ID. So think about them, because these are more common presentations. That being said, if you have any doubt, please refer to PIDS early. The younger, the better, so that we can make an early diagnosis. We probably can give some parents relief. We can start early intervention programs, and we are able to prognosticate and know what to expect from this child, right? We can also discuss about family screening, family planning, as well as future pregnancy. Okay, bits and pieces from our neurodivergent kids. Thank you for your attention.
Testing. Hello. Assalamualaikum and good morning to distinguished guests, professors, doctors, and fellow audience. My name is Nisa. I'm a clinical psychologist from Psychiatry Department, and this is Ms. Tamil Mogil, who is my trainee. We co-manage this case together, which is an interesting case specifically for behavioral intervention. Our focus is on behavioral intervention. So to be honest, my personal experience when I received the referral letter and read the history of presenting issues, I feel that, for a long time, this case has been co-managed with OTs and several other departments. I think it's a bit challenging, and I already have a certain mindset of how the patient would be, NSA would be. But I think while working with them, we've seen different part of her, which I would like to share with you today. So this is just a little bit information about her, because I think Dr. Divya has already shared a lot about this. We call her NSA for today. She's 21 years old, female, Malay. Then the diagnosis is SMS with intellectual disability and mood dysregulation. So we got the referral letter on earlier of this year, 24th March 2025. And the reason for referral, there's a lot, but we'll focus on these three first, which is pass urine inappropriately in pants, which is similar to mom shift complaint, which I'll present a bit more later. And she usually remove clothes and sleeping naked, and of course the temper tantrums, aggressive behavior, especially in social settings, social events. Okay, so mom is quite worried about patient. I think the sentence that she actually voiced out to us is, "Please don't give up on my child." She was very stressed when she said about the urination problem. So a patient usually will delays the urination intentionally, despite she's aware of the need to go to the toilet, and which makes she pass urine inappropriately. Like, for example, when she watch TV or play phone at the sofa, she will just pass urine. Or when she's lying on her bed while doing nothing, she also pass urine on her sister's bed. So that caused a lot of pressure to mom and other family members, as they really need to repeatedly clean up for her after the urination happens. This also introduced a pattern where when she pass urine, and then mom will try to confront her that you pass urine, and she denies, despite that she truly pass urine. And then she started to argue with mom, and the temper tantrums happen, and sort of like it is in a repeated unhealthy patterns. About the remove clothing, even with air conditioner or without air conditioner, trying different clothes, sometimes she will just remove her clothing and go into like a public area inside the house, which then cause uncomfortable feelings to other family members in the house, especially her brother-in-law. So mom is also very worried about that. I think lastly is, of course, the frequent temper tantrums and episode of loud yelling. I was being warned before when I got the referral letter from Prof that say that, Nisa, be careful. Sometimes she can use vulgar words. She didn't mean it, of course, but just be careful. But fortunately, we have understand that in the session with medical doctors, for example, usually there will be a lot of audiences, students, and a lot of multidisciplinary team, like from family medicine. So she kind of wants some attention from them, and she started to act out to get attention from adults, especially. So we try to be to have a session where only small with the therapist, just the two of us, with Miss Mugil. So that helps. And fortunately, NSA is able to cooperate and without any use of vulgar words. Okay, so I will also share about parenting style, because I think one of our intervention approach is also to focus on empowering parents to become more, to become more aggressive, or to become more empowered to tackle NSA and not be afraid of her behavior, but mostly guide towards appropriate behavior. So when she was a child, usually she was living with her grandparents, maternal grandparents, and we know that her maternal grandparents usually just give her everything that she wants, which then caused the learned behavior now. But now, parents started to show a little bit more physical consequences, such as like tapping on the leg, for example, if she shows physical aggression like kicking. So they started to try, I think based on the OT intervention, they have started to try different ways to approach NSA. Before this, behavioral strategies like star charts, rewards are not effective because, with permissive parenting, common reinforcers like chocolates, she can always ask from her grandparents later on. So why bother achieving the star chart? Because she can always ask again, right, from the grandparents. And so now we try a different approach, and hopefully it helps in the long run. So we wanted to know her level. IQ tests are not really suitable to be done on her because she has a short attention span. Even in our intervention, we need some break session to do things that she likes, which is coloring. So that's kind of self-soothing activity for her. So we did the webs with her mother, interview assessment with her mother. So this is the result. So I'll explain a bit about her result. Based on communication part, which usually include language, her receptive is very low, as you can see here. At 3 years, 6 months of age, she can understand instructions, but she needs frequent prompting, frequent reassurance, and frequent repetition. Like repetition is really needed for her to understand. Her expressive domain, she can converse now, but you you will have difficulties to understand her. The stories is quite irrelevant. It's incoherent with each point, so it's up and down. We need to be really slow to understand her stories and to get information from her. On the written part, she's not able to write even A to Z or 1 to 10, and she can't even recognize alphabets and numbers. Okay, for the daily living skill, this is a bit tricky and complex because for the personal part, like for example, hygiene, parents try not to let her do hygiene on her own because they are afraid of it's not clean. She has, I think, based on history, she has the history of playing with feces and playing with soap, and she tend to put it on her mouth, which then will induce diarrhea, which she will usually have, and it's common in patients with SMS, and that exacerbate the passing urine and now passing stools. So the parents need to clean, and they sort of like, oh no, they will just take care of her hygiene and not let her do herself. So that's a bit tricky. It could undermine her ability to learn about her personal hygiene and daily living skills. But it is also quite low. The age equivalent is mostly 4 years and below. For the socialization part, this is related to social and emotions and coping. We can see this is the lowest among the other domain, which is, I think, proven in research. I think Prof. Wan will elaborate on it more. But of course, the emotion part, we can see that if she didn't get things that she wants, she can't really tolerate frustration. So this is a little bit of assessment of her adaptive behavior skill. I'll pass the floor to Mugil, who has already seen.
So, hello. Thank you, Panisa. So, I'll be presenting based on her interventions conducted with patient NSA. So, we initially wanted to understand better on her behavior and also on the goals why the behavior occurs. We analyzed using 3 key incidents by using antecedent, behavior, and consequences chart. So this helped us to understand and address those challenging behaviors. So for the first incident, it's about passing urine inappropriately. During the antecedent, she engaged in her preferred leisure activities such as playing with her phone, watching TV, lying on bed, and also sofa. So usually this happens for a longer duration. However, in a 3 hours of interval, the mom will remind her to go for toilet. However, she would refuse when her mom goes to toilet. So she ends up urinating in her pen or also in the bed or sofa. When her mom's confront about that behavior, she would deny about it, and this escalates to shouting, kicking, or hitting behavior. In response for the consequences, her mother would scold her, and she would continue to yell and cry on the floor. Other family members would just stay quiet or ignore her behavior. However, her mom would take away her handphone as a punishment. So we managed to identify that the goal of this behavior might be a way for her to serve as an avoidance from interrupting from her preferred activities, to maintain comfort, or perhaps reflect her low awareness or urgency due to her cognitive level, to identify whether she wanted to, why is the need for her to go to the toilet. Instead, she can do it on the bed, on the sofa. So she might also simply prefer the convenience of staying in a place over the effort of going to the toilet. And for the next behavior, the antecedent usually happens only at the night, which is removing clothing. She tends to sound sleep at the living area with her sister, and even when the air condition is on, she still would remove her clothes. The behavior would happen when her moms confront her. She would roll herself in the blanket and she would just walk in her kitchen nakedly. And she also appears to be comfortable with that behavior since other family members would be asleep. So the consequences of this behavior, mother tends to attempt for negotiation by allowing her to skip innerwear, but she still continues to prefer being unclothed. So this goal behavior is still under exploration in terms of whether it's a sensory-seeking behavior, whether she prefers skin contact with the blanket, or to have the feel of the air. It might also relate to the temperature regulation or the comfort, while attention-seeking is less likely since others are still asleep, but this goal is still under exploration and you might explore it in our upcoming sessions as well. For the next behavior is about crying at shopping mall. This usually happens when she's being denied on her desired items such as stationery, toys, and when she's being denied, she would react with loud shouting. She would also challenge the staff over there. She would ask them, "What are you looking at me? What happened?" And she also will lie down screaming for up to 20 minutes. Parents usually does not give in to her behavior, but they tend to explain to the bystanders to ignore her behavior as well. So father also will ask the mother to leave the area. However, no purchases will be made. Instead, the father will just leave her alone, but he would warn her that others might scold her. However, she would just reply that she's not afraid of them. So this behavior might suggest her primary goal might be to get access for her desired item. This also can be related to the parenting style which her maternal grandparents giving everything whatever she asked when she was living with them. And a possible secondary goal is that gaining attention through her reactions, even though those are aggressive. So based on this, since the consequences-based strategies were limited in reducing inappropriate behavior based on the studies, we decided to shift the focus on the antecedent strategies. So this involves proactively shaping her environment and routine before the challenging behavior happens. So for the first part of the antecedent, which is the passing urine inappropriately, we implemented a social story intervention to improve her toilet training and also to reduce passing urine behavior inappropriately. This is to enhance her understanding of toileting routines through visuals, reflective, and pretend play activities. Together, we also wanted to empower the mom by providing psychoeducation strategies to support her toileting behavior at home. So throughout the session, she actually showed positive engagement and excitement with social story, particularly in response to real-life images of her home. We tend to get images of her toilets, of her bedroom from the parents and incorporated that in the social story. So she was very excited and she identified the character of the story as Kakak Siti. However, throughout the end, she managed to substitute herself into the story and demonstrated that she understands the flow of the story as well. So she was able to also participate for almost 45 minutes and she was provided with 10 minutes of coloring task as a break. After that, we managed to perform a pretend play activity for the toileting with minimal prompting. So later on, we will be showing a video on that as well. For the empowerment of the mother, we explain how does a social story helps her to promote her toileting behavior. So mom directly reflected on the benefit of using gentle language such as cuba buat, instead like she previously tend to use kena, perlu, that kind of terms at home. So we also provided a tracking worksheet and psychoeducation on consistent use of social stories and also to track how many times she was able to go to toilet with prompting and also without prompting. So this would be the video for the social story.
Siapa nama dia? Kakak. Kakak? Oh, kakak ada nama tak? Ada nama? Ada. Ada. Nama apa? Kakak. Kakak siapa? Ada. Kakak Safia. Oh, cantiknya kakak Safia. Okay, nak letak nama tak untuk kakak Safia? Boleh. Okay, nama siapa? Siti tak? Siti. Okay. Apa Siti nak buat hari ni? Tak ada apa. Nak buat tangan. Okay, Siti nak belajar. Belajar apa? Belajar nak pergi Boleh. Yeay, bagus. So, mari kita capture lah. Oh, ya ke? Okey, macam mana nak tanggalkan? Tanggal dekat. Cuba buat. Yes. Sampai ke dari atas ke? Dari bawah. Saya pakai seluar dalam dan pendek. Seluar. Okey, tadi kita dah turunkan. Sekarang naik balik. Kita cuba naik balik atas. Tak mana? Atas. Pakai balik. Jom, kuat sekali. Okey, dari bawah naik atas. Boleh? Boleh. Okey. Ni bilik air kan? Dekat sana kita boleh buat apa? Bilik air. Boleh? Nak. Cuci. Buka air. Siapa nama dia? Kakak. Okey. Kakak. Cuba tekan. Kakak ada malu. Sama macam Nadia.
So next would be for the pretend play.
Okey, dia rambut. Cuba pegang. Malu. Sama macam Rafia. Ada budi. Yes. Buat. Jalan, pergi cuci tangan. Wow. Nak yang ni. Okey lah. Okey, cuci. Okey. And then nak pakai tisu, lap tangan. Kanan. Tutup pintu. Yeay. Bagus.
So next would be for the remove clothing at night incident. Before initiating for the new intervention, we conducted a progress update on the toileting with the patient as well. She mentioned independently that she able to bring back the take-home worksheet, and she also expressed her happiness in the toileting progress. She mentioned that her mom is not scolding her anymore, and she also is able to go to the toilet back again. So from there, we shifted the intervention for the remove clothing at night. So when asked about her intention, why she's removed clothing, she was a bit reluctant, and she was stating that she's not interested in wearing those clothes at night. However, to increase her understanding and compliance with wearing clothes at night, we tend to use social stories, videos, and pretend play interventions as well. So she was highly engaged with the video, storybooks, and pretend play about keeping those clothes. And towards the end, she was able to understand the reasons of wearing the clothes by saying that she doesn't want to be naked as well. So this is the outcome at the home for the intervention conducted for the urine incontinence. Mother noted that over the past 2 weeks, patient successfully requested to use the toilet at least 11 out of 26 times, particularly when prompted. She also successfully passed urine or motion in the toilet for 21 out of 26 occasions instead of urinating in her pants or also outside the toilet. As a conclusion, the parent also reported that this is a significant improvement and expressed their intention to continue providing prompts at home. Okay. So a further intervention will be conducted for crying at shopping mall. This will be using a simplified visual materials. And finally, as a recommendation, we would be psychoeducating parents to continue the daily use of social story, and then to reinforce additional toileting tasks, and then to repeat and review them continuously and set achievable dressing goals such as just wearing innerwear first at night. And then for emotional regulation, we provide a simple functional communication such as just asking, "Can I have wood?" just as requesting at the shop. And finally, to encourage parents to maintain a consistent language and avoid using punitive phrases, and also provide a complete summarizing strategies for future guidance. And that's all from us. Thank you.
Sorry. Okay. Assalamualaikum warahmatullahi taala wabarakatuh, and very good morning. Before I start, maybe let me I want to thank all the speakers for their very good and comprehensive presentation, and also for collaborating, and also for sharing your good work with this patient. Okay, so I'll be focusing.
Okay, so I'll be focusing on the psychiatric aspects mainly. What are the features, our role, what we do, our management, and also the challenges that we face. You've heard what Smith-Magenis syndrome is, yeah. So I'll skip that. Okay, so challenging behavior is one of the main feature in Smith-Magenis syndrome. So very high prevalence of self-injurious behavior, head banging and body hitting. They also have onychotillomania, nail picking, polyembolocoilemania, I hope I pronounced that right, the self-inserting objects or things in body orifice. Aggression and property destruction are also very high, and about 50% have stereotypic behavior, the characteristics, self-hugging, hand squeezing, and so on. So the unique thing about this syndrome is that this behavior starts early as 18 months. So in this case, I think it's about 3 years, but the behavior can start as early as 18 months. It tends to intensify with age due to the developmental asynchrony, and also may escalate during the different developmental phase and transitions such as puberty. So many of the behavioral profile described in Smith-Magenis syndrome are actually features that we can see in the younger kids, yeah? The attention seeking, poor tolerance to frustration, need to be independent, and also separation anxiety. Having said that, please don't go away just with the challenging behavior, because they also have positive attributes. For example, they may have engaging and enduring personalities, eager to please, good sense of humor, a strong need for adult attention. They can be particularly affectionate and communicative. But however, when coexist with significant emotional immaturity, that can lead to challenging behavior. Okay, sleep disturbance is another common character, and this is very important because sleep disturbance itself can contribute to challenging behavior. So what are the characteristics? Shortened sleep duration, frequent nocturnal awakenings, early morning awakenings, daytime sleepiness. In older children and adolescents, they can have difficulty initiating sleep, and also sleep attack, suddenly the urge to suddenly sleep. I think you heard our patient just now, like she can fall asleep while eating. Yeah? Okay, and this is all related to the altered RAI1 gene, which cause a dysregulation in the circadian rhythm, inverted melatonin secretion, as well as the physical features, the facial anatomy, hypotonia, and the obesity-related problem. Food-related behavior is another common characteristic. So things like they are preoccupied with food, taking and storing food, inappropriate response to food, and also impaired satiety. Again, it's related to the RAI1 gene, which downregulates BDNF, and BDNF has been linked to obesity and hyperphagia. The behavior can start as early as 5 to 11 years old. Okay, what are the other psychiatric manifestations? They can have neurodevelopmental conditions as well, ADHD-like symptoms, ASD-like symptoms, as well as intellectual disability, which is very common with different levels of severity. Commonly, they have mild to moderate ID. The other aspect of mental health, the mood, the anxiety symptoms, these are common as well, and OCD-like symptoms. But the difficulty or the challenging part is how to make a reliable diagnosis in these children, yeah? But these are not uncommon. Okay, so I think parental challenges is evident and also supported by literature. Okay, so what are the challenges that we face? She's the one and only case of Smith Magenis that I have, and I must say, like, we face a lot of challenges in managing this case. So first of all, the challenging behaviors are genetically determined behaviors. So this is the behaviors, the aggression, the self-injurious behavior are part of the syndrome itself. To make things more complicated, there are environmental triggers that can also trigger this behavior or worsen or maybe reinforce. Developmental asynchrony is said to be the core factor that makes SMS very challenging. What we mean is that the different developmental aspects do not progress at the same rate, particularly the intellectual and the emotional maturity. So in her case, for example, she passed urine. She has some intellectual capacity there that she knows that the rule is that you don't pass urine outside the toilet, but she broke the rule. And when mom told her not to, she developed tantrum because she doesn't have that emotional capacity to regulate her emotion. Behavior changes and evolve over time, so we have to keep changing our strategies as well. So that's challenging. She has various medical conditions that can interfere with our management. For example, the hypercholesterolemia and our antipsychotic metabolic side effects. And finally, parental distress can also contribute to the challenges. Okay, so it requires a multi-disciplinary team approach. Pediatric geneticists is the main figure here. Unfortunately, Dr. Keng cannot be with us this morning. Psychiatrists to treat the psychiatric manifestation. Our psychologist colleague more on implementing the behavioral and psychological intervention, medical specialists to treat all the medical condition, OT with sensories, ADL, and speech with speech language communication intervention. All right, so I'm zooming into psychiatric management. So when we manage behavior, we have to understand what is the reason. So challenging behavior commonly communicate distress. So we have to understand what is the distress, okay? So by using a help model or thinking through help model, it provides us with systematic consideration of all the possible factors that might influence a challenging behavior. So H for health. Always consider all the SMS-related physical or medical conditions. E for environment and expectations. Factors like sensory processing issues, environmental triggers. L for life events. Factors like bullying. Our girl, she was bullied in school. There were name callings that leads to aggression to her peers in school. They are vulnerable to abuse, trauma, and so on. And P for psychiatric. So obviously they can have problems with mental health, and that should be assessed and considered when there's challenging behavior. But again, the difficulty would be how to make a reliable diagnosis. Okay, so this is an overview of psychiatric management, behavioral assessment. You heard this a few times. The ABC, always consider developmental perspective. Psychological and pharmacological interventions, I'll go into that a bit later. There are environmental modifications that we can do to prevent or minimize a challenging behavior, and parental family support and also school support is very important. Okay, so sleep disturbance is very important because sometimes when you manage sleep effectively, it may reduce the challenging behavior. So strategic sleep scheduling or behavior interventions such as having consistent bedtime routine, structured daytime activities, using positive reinforcement, and so on. There are medications that we can use, exogenous melatonin, commonly used for the night sleep. The other strategy is to combine it with beta blocker or stimulants to treat the daytime sleepiness. Melatonin receptor agonist, although not specific for SMS, but FDA approved for insomnia and also depression with the sedative effect can be used to treat sleep. But this is only FDA approved for adults, not in children. Light therapy is currently being investigated, and some other medications that have been used, including quetiapine. Okay, so management of challenging behavior. So I think I want to emphasize that what we found in Smith-Magenis is that consequence-based approach is effective in reinforcing or maintaining behavior, but it's less effective in decreasing the inappropriate behavior. So normally antecedent strategy is recommended. So like you work and trying to achieve the appropriate behavior and later reinforced by positive consequences. Again, you have to start with your ABC analysis. Antecedent strategy means that you try to identify the trigger that commonly leads to the challenging behavior. When you see it coming, you distract and engage them in other appropriate behavior. Consequence-based is based on the principles of reward and punishment, environment and structure, implementing structure, predictable routines, and well-defined limits will help. Consistency, I would say, is the key. So you have to be consistent with your expectations limit. You have to be consistent across different settings. You have to be consistent within time, and you have to be consistent between the staff and also the caregivers that manage. So other support and strategies like visual support, simple language like using first then language, and also pairing the non-preferred activity with the preferred activity. Okay, so there are also pharmacological intervention for challenging behavior, but please remember that medication is not first line. Okay, we use medication when behavior intervention fails or not enough to control the behavior, or the risk is too severe that we have to use it. But again, not to use it alone. It has to be combined with behavior intervention. So we use antipsychotic. It's not SMS specific, but FDA approved antipsychotic for irritability are risperidone, and aripiprazole can be started as early as 5 to 6 years old. And these are the medication that she's on. Mood stabilizer, however, unfortunately, doesn't really have a conclusive evidence in terms of efficacy. We use stimulants and non-stimulants for ADHD, and antidepressant can be used if you suspect there's depression, anxiety, or OCD symptoms. Okay, so I think when we talk about SMS, family is very important. It's very important to support family. We offered individual counseling for the parents. Unfortunately, it's a rare disorder, and I think very small numbers in Malaysia. I think she's the only one in HUKM, if I'm not mistaken. So, but parents can access all these international resources. They are very good and also accessible. Okay, so it's been a 15-year journey. I didn't realize that until I prepared the slide. She was first referred when she was 6, and she's now 21 years old. So where are we now? I think in terms of challenging behavior, there's up and down, and escalating during puberty. So there's a bit of improvement in terms of physical aggression and sleep disturbance. And when we discuss with parents regarding which behavior to focus, she wants to target the passing urine and also the inappropriate naked behavior. So they're working on that, and very positive improvement with toilet training. And again, the challenges is how to provide consistency to empower parents, and also generalizing the therapeutic progress in clinical setting to home environment. And I must say I'm very anxious now because Mugil is leaving. She's finishing her posting. Nisa will be going for her antenatal soon. So yeah, we have to have good strategy. Then when we have established that, when the behavior more stable, our aim is of course to reduce to monotherapy. Okay, it's not polypharmacy, it's not the principle here. Then again, what I guess help us is when we support the family never give up. We should never give up. So family support and collaboration with other multidisciplinary team really help us to work with this patient. And for future consideration, I think I'm not being too ambitious, but I think we can achieve this. Like maybe I'm hoping that when things better and into place, maybe we can send her out for a short, maybe a community, a vocational program, and which can also give respite for her parents. So, okay, so I would like to end with this beautiful and I think very inspiring quote from the PRISM's website. With that, I thank you very much.
Sorry, can I ask a question? Prof. Chan, I think both of us have to go for another meeting, but this is just another quick question. On behalf of medical students, can you raise your hands, siapa, medical students? Okay, because the thing is, this child, I mean, retrospectively, I mean, being in the shoes of the parents, have lost 5 years of the early intervention. So to get an appointment to see an expert will take a long time. So medical students will be our future frontliners. So what will be your advice to the medical students who are going to see a lot more behavioral, I mean, this kind of cases in the future? I think that's all my question. Thank you.
So you mean with regards to the behavioral challenges, not the diagnosis?
Not because I think the most important thing, I mean, the diagnosis is important,
Yeah.
but the problem that is staring at you is so obvious, the
Yeah,
behavioral change. So how do they address this, especially to the parents when, I mean, the appointment will be another 3 to 4 months, right?
Yeah.
So what can they do to reassure the parents and start the intervention?
Yeah, I think you will have to assess the severity as well. When the case are referred to us, we also will try it. So if the behavior is severe, we will put this as urgent. But again, then your referral must be clear as well, because sometimes we are not sure whether this is urgent or not. So coming back, I think you have to assess the severity of the behavior, whether it can be managed at your level or at your setting. But if you think if it cannot be managed, it's not improving or it's worsening, I think that is kind of indication to refer. If you're not sure, just give us a call to, like sometimes it doesn't hurt to give us a call and tell us your problem so that we can kind of advise accordingly.
Thank you so much, Prof. Sharul, for that important question, and Prof. Wan for explaining how do frontliners actually deal with challenging behaviors in maybe a syndromic child. Maybe I just want to close this CPC, there are no other questions, by I suppose just some reflection that sometimes it may seem impossible to help a child and the family with super challenging behaviors, and we might feel at a loss. But I think today's CPC exemplifies the power of shared expertise in terms of a multidisciplinary team. Not only the pediatrician with neurodevelopmental subspecialty, the psychiatrist together with the fellow who work hand in hand, as well as the clinical psychologist and her very important trainee who is there on the ground to be able to do all the behavioral approaches to manage the challenging behaviors. So with that, I'd like to close the CPC and thank you so much to all the speakers and everyone for attending. Thank you very much.